Over the last 2 decades, the Western Cape Provincial Department of Health has gradually implemented patient administration systems in all fixed public sector facilities.
Because of the availability of quite a large amount of person-level health data from administrative systems, such as the pathology services or pharmacy dispensing, it is possible to create a fairly rich person-level shared health record in the absence of an electronic medical record.
The Provincial Health Data Centre, PHDC, was initiated in 2015 with the aim of supporting service delivery by enabling continuity and quality of care while also providing health system intelligence.
The Western Cape gradually, over a period of 20 years, implemented a common hospital information system, and they expanded the unique identifier within that system to primary care. And that immediately created the opportunity to start working with patient data. So the District Health Information System, which is the standard way of managing health data, is based on very prudent delineation of indicators, which are collected through carefully designed registers and source documents at facility level. And those indicators are very prudently chosen because we're asking health professionals to go to extra effort to record them purely for monitoring purposes, normally without any benefit to the patient. And so that whole science of minimum data sets evolved around the District Health Information System, and that really has been the mainstay of health information systems. And the Provincial Health Data Centre was an explicit movement to augment that, not to replace it, but to augment it with leveraging person-level health data.
At the PHDC, we've been integrating patient-level data from all the routine health information systems in the public sector for over 5 years. This has largely been possible due to the widespread use of the unique health identifier that is shared across the health information systems, making data harmonization that much more easy. Our data center contains data from over 30 sources for over 14 million patient identifiers, and in some cases, the data sources go back over 20 years. Even my now long since deceased great-grandmother has an entry on our patient registry. We incorporate most of our data sources daily, which means that our reports and applications give visibility to data that was captured the previous day, and this has really allowed the data to be actionable, and it's already been used in an actionable way for TB case management and HIV case management.
The activities of the PHDC are broadly characterized as harmonization and curation, data beneficiation, and data provision.
So the second objective of the AHIE consortium was to develop the patterns for data consolidation and integration, curation, common terminologies, and to find ways of processing those data that would best be able to support operations.
Source data are received through several mechanisms and are then harmonized into the consolidated PHDC architecture.
And then finally, within the Western Cape specifically, where the data consolidation was being prototyped, there were many other person-level health systems. We had about 20 different systems within the Western Cape that gave us the opportunity, using the unique identifier, to really explore some of the patterns that would work with multiple disparate systems that could be linked on a unique identifier.
In curation of the data, each data point is mapped to a person through linkage on the Patient Master Index, or PMI, and also to a location and standard ontology, such as ICD-10 codes for diagnosis, ATC codes for medicines, and where possible, LOINC codes for diagnostic tests.
Key features of the PHDC that I'd like to highlight is that once our data are imported, we have automated and manual curation processes that enable the data to be cleaned and mapped to common concept dictionaries that can be shared across the sources. We then try to get the maximum benefits out of all the data by inferring things like health service encounters. For example, if a patient was dispensed a drug, we can infer that they visited a facility on a given day. And just knowing a patient's movements across facilities can provide a lot of information about their health. However, we also infer health conditions from the data. Unlike many other systems in the private sector and internationally, which largely rely on the use of clinical coding, such as ICD-10 and SNOMED codes, we use all the routine data, such as the lab results and the drugs dispensed and the ward information, to infer the conditions a patient may have. And all this information is exposed to our users via actionable tools, These include things like patient-level list reports that can be used to filter patients that are in need of follow-up. We also send out patient-level alerts every morning to requesting health providers to notify them of patients in specific need of follow-up. And we've developed an application called the Single Patient Viewer, which exposes the electronic medical history of a patient, combining all the key information that would usually have been stored in paper folders across various facilities.
Data linkage comprises linkage within the PMI to identify all possible PMI duplicates, as well as the linkage of all attribute data from source systems to the PMI.
When a patient arrives at a facility, the clerks would check if the records of that patient already exist in the system. If they don't find them, then they will create a new record. But sometimes, because of clerical errors or misspellings, they would not find a record for that patient, even though it exists. So they will then create another record. Data linkage essentially is a process of identifying records that belong to the same person. So you have two data sets, you try to find records that belong to the same individual. Then there is a special case of that where you also have multiple records for the same person in the same database. Let's say we want to link data that sits in different or disparate databases, but each of them carry that unique identifier. It is easy because it becomes just a situation of just joining on that patient identifier. But sometimes that unique identifier is not available in other databases. For example, specialized databases, maybe they will be using an ID or some other identifier that is local to that system. They're sometimes called quasi-identifiers. So I think that's essentially the process of record linkage. If, for example, we have 1 million records and we find that 200,000 are duplicates, then we resolve those duplicates and remain with 800,000. It means we are getting more accurate.
Rather than relying on high-quality coding to determine health conditions, Phdc infers health conditions by leveraging a range of data sources. Only inferences with high certainty are used for clinical tools such as the Single Patient Viewer.
When we create episodes, which are disease conditions, we do infer them from the data we have. So we would need the labs, the tests that have been undertaken, the drugs that have been dispensed, and also if we can get like those specialized databases like data from TB systems and any other information we always enrich. I think the more the merrier.
One of the key differentiators of the AHIE approach from traditional approaches is the fact that we are relying very heavily on administrative data. It's still clinical data, but it's collected as a byproduct of administrative systems, and stitching it together to create a patient-centric view, which has the potential to get to maturity a lot quicker than monolithic electronic medical record systems, which require huge infrastructural dependencies to get to the level of coverage required to make sure that you know where every single person is in the care continuum at every point in time. The analytic challenge here is very straightforward. It's actually a binary predictive model. Either a person is in care or they're not in care. If they're not in care, they're not doing well. And knowing whether they're in care or not is actually the complicated component because of the very disparate systems. So one of the unexpected initiatives was when COVID-19 became a healthcare crisis in 2020. And because the Provincial Health Data Centre was in place, and the Single Patient Viewer was in place, having the data center with all the patterns that we had developed for integrating and ingesting data and having the people. And I have to stress that the most important component of AHIE is demonstrating the value of people with the right data competence within government. Having those people in place who could rapidly adapt to this new challenge enabled us to create an end-to-end information system to integrate the various laboratory, hospitalization, mortality data into a COVID-19 data system, to be able to answer research questions around COVID-19 in an information-free zone, such as what the impact of HIV and TB were on severe COVID presentations and COVID-associated mortality. And then to be able to create an outbreak workflow to support the track and trace. We could integrate data from the national track and trace system, which SMS'd people their results and engaged them in bidirectional cell phone-based contact with the National Department of Health, and we could integrate those data into our information system. The consolidated data environment that we have in the Western Cape is probably quite unusual in the African context, because we have a level of digitization, especially of health facilities in the public sector, that is a little bit ahead of other areas. And so we've prototyped some of the data consolidation approaches earlier than others in similar context. We've published those, and from that we've had a lot of interest and feedback. And I think the role that it's playing globally is kind of demonstrating proof of concept that this is possible in a resource-limited setting, demonstrating that the consolidation and interoperability approach is viable. So I would say that the unique value of the AHIE approach is not relying on a single megalithic electronic medical record system for everything. We've seen those systems go wrong both because of lack of coverage, delays in achieving that coverage, supply chain issues with large IT systems, especially with weak healthcare systems. Whereas an interoperability approach that tries to leverage whatever data is there and then iteratively improve it often stands much better chances of success. And in fact, often one can start using the data a lot sooner than waiting for maturity of a monolithic system.